Hello, 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 ladies and gentlemen. Today we are talking about human immunodeficiency disease, otherwise known as HIV. So, the learning outcomes for HIV. We will summarize the pathophysiology of HIV disease and the progression of HIV to AIDS. We will identify the diagnostic studies used as screening tests and the follow-up assessment for HIV. We will differentiate the abnormal assessments that are commonly seen in patients with HIV and AIDS to a normal adult assessment. So we are going to look at what we consider normal, quote unquote, or within the normal limits, and then we will look at what we are seeing with someone who has been infected with the virus. And we will judge the appropriateness and safety of administering the more common medications that are used for the treatment of HIV disease. We will evaluate the needs of clients with HIV and AIDS and or their families, because this is no longer considered a death sentence, essentially, as far as we have come in the treatment of HIV with medications and with patient compliance with lifestyle changes. This is now considered a chronic illness, believe it or not. So there is a lot of patient education involved for the patient, for the patient's partner, for the patient's family. So in order to prevent and manage the opportunistic diseases that are going to come along, because now in these times, more often than not, an HIV client or an HIV patient or an AIDS patient will pass away from an opportunistic infection rather than the virus. And because we are nurses, we will formulate a nursing plan to care for a client that has been diagnosed with AIDS. So let's talk human immunodeficiency virus. Excuse me, it's very early in the morning here. So HIV disease. HIV disease is caused by the human immunodeficiency virus. It is now considered a chronic illness. It is comprised of many stages, ranging from the acute infection to when the client will pass. But again, now we are seeing that clients are passing more from opportunistic infections than the virus. An HIV-infected individual who does not receive treatment, the length of time from infection to his passing is approximately 12 years. In resource-limited countries, the time from infection to death is approximately 5 years. So, HIV, malnutrition, tuberculosis, otherwise known as TB, and malaria are comorbidities that will shorten the lifespan of the untreated patient. In June 2016, the 35th anniversary of the first reported cases of acquired immune deficiency syndrome AIDS was in the United States. So it has been here for almost 20 years now. June 1981, the Center for Disease Control and Prevention, which is the CDC, reported confirmed cases of pneumocystis carinii pneumonia, otherwise known as PCP, in 5 previously healthy gay men. So this was a virus that, when it emerged, was prominently defined in the gay community with gay men. Because this disease only occurs in individuals with severely compromised immune systems, it is named acquired immune deficiency syndrome, otherwise known as AIDS. So in 1985, the first antibody test for the HIV virus first became available. Positive antibody tests confirming the presence of HIV antibodies were found in individuals who did not have signs or symptoms of AIDS. So They had the antibodies, which means, as we know, they were exposed to the virus, but they did not develop the virus. In 1986, the CDC published a disease classification system for individuals with a positive HIV test. So, individuals were categorized into one of 4 mutually exclusive groups on the basis of the presence or absence of signs or symptoms associated with HIV, which means that we looked at the whole entire population, and then we created these 4 different categories. And then, looking at the data that we had collected, we put these clients into one of 4 categories. The first recognition of the continuum of HIV/AIDS as a disease that progresses through stages from acute HIV infection, asymptomatic HIV infection, symptomatic HIV infection, to the most advanced stage, which is AIDS. So these are the 4 stages: acute HIV infection, asymptomatic HIV infection, symptomatic HIV infection, and then the advanced stage, which is when the client develops the AIDS virus. So currently, anyone infected with HIV, regardless of the stage, is considered to have an HIV infection. So now what we're saying is symptomatic, asymptomatic. If you're infected, we're just going to say that you have the virus. That's it. In adults, the illness is categorized into one of 3 stages based on the Cd4 lymphocyte count, the Cd4 percentage of the total lymphocytes, and the presence or the absence of certain infections that are commonly found in individuals with compromised immune systems. And so a compromised immune system will also be called, will also be susceptible to an AIDS-defining condition. So all of this, okay, how they get categorized into these stages is going to depend on their Cd4 count. That is the key to everything, the Cd4 count. So, if an individual has an AIDS-defining condition, they are considered to be positive for AIDS, regardless of their Cd4 count. In my textbook, it is table 21.1, page 409. I'm not exactly sure in the newer edition. So again, if an individual has an AIDS-defining condition, they are considered to be positive for AIDS, regardless of what their Cd4 count is. Criteria for HIV infectious stages are different for infants and children under the age of 13, but I do not deal with pediatrics. I do not talk about pediatrics. So for us, that criteria will not be pertinent to what we're talking about. Outside of the United States, a classification of HIV infection in adults and children has been developed by the World Health Organization has been used. So, outside of the United States, in those underdeveloped countries, the criteria is based on the World Health Organization criteria. So, ladies and gentlemen, listen up, and then listen up one more time for me. According to the Joint United Nations Program on HIV and AIDS, in 2010, approximately 33.3 million adults and children were living with AIDS. Well, that has been over 10 years ago now, so we know that that number has only grown. So listen up, listen up, listen up. Until a vaccine is available. Right now there is no vaccine, but there are medications that will help control the viral load. So until a vaccine is available, eliminating risky behaviors, and it is these risky behaviors that will lead a patient to become infected with this virus. So eliminating those risky behaviors such as unprotected sex and IV drug use will provide the major intervention to reducing the transmission. So we need people to eliminate these risky behaviors, have more protected sex so that they are protecting themselves, they are protecting their partner, and of course, no IV drug abuse. In 2010, UNAIDS estimated that approximately 2.6 million people were newly infected with HIV. So again, that number is over 10 years old. The number has only grown. This number reflects a slow decline since the peak in 1997 due to the emphasis on prevention. So there is more awareness, there are more medications, more research, more of everything, more education on how we can prevent this virus. Due to the increased access to care and treatment, death has decreased to 1.8 million, with an increase in the number of people living with HIV. So this means that people who are infected are living longer with this virus because, again, now it is considered a chronic illness, and less people are passing away from HIV. But again, they are passing away from these opportunistic infections. So in 2013, the CDC estimated that since the beginning of the epidemic in the United States, approximately 1.7 million adults and children had been infected and 600,000 had died. Currently, approximately 1.1 million people are living with HIV in the United States, and about 15% are still unaware that they have been infected, and that is because they just have not sought out to be tested. They are living under the radar, so to speak. In 2010, the CDC indicated the new infection rate among gay men was 63%. This is new infections, the highest of any group. So this means that just like anything else, once we get comfortable, once we know that there are medications, once we know that there is treatment and prevention, we start to relax and we don't pay as much attention. And we see that now, right, with the COVID virus. More and more people are getting vaccinated, which is a wonderful thing, but sometimes, and you may hear people talking, well, I've been vaccinated, so maybe I don't need to wear my mask as often. Maybe I'm relaxing my hand washing. Maybe I'm not wearing my mask outdoors anymore. Maybe with other people that are vaccinated, I'm not worried about social distancing. We begin to relax a little more. So, again, ladies and gentlemen, please listen up, and then listen up one more time. In early 2000, the highest new infection rates were among IV drug users. And now we are bringing in the heterosexual community. So heterosexual transmissions, which means that there are people who may be more and more aware of their sexual orientation, and I am relaxing my restrictions. I'm involved with men, I'm involved with women, and maybe I am relaxing my method of safer sex. And then there is the IV drug abuse community. So most racial and ethnic groups are affected is the African Americans. In 2010, again, over 10 years information, the CDC stated the highest rate of new infections were among different racial and ethnic groups in African American men who were having sex with men. So the bottom line here is HIV affects different populations differently. And again, that is because we are relaxing our lifestyles. So, the highest incidence of HIV infections are found in Washington, D.C., Louisiana, and Maryland. The lowest is in Vermont. Ladies and gentlemen, listen up, and then listen up one more time. Most commonly, a sexually transmitted disease, although a significant number of people will contract the disease via IV drug use. Ladies and gentlemen, listen up one more time. With IV drug abuse, blood containing the virus is injected into the bloodstream from an infected person. So this is the sharing of those needles or those syringes. And there are so many programs right now. So many programs where you can turn in your syringes and you can get clean syringes. There are drop-off spots. There are pickup spots. This does not need to be anymore. But people will do what they do. Since 2002, one reported case of HIV through occupational exposure. So this pertains to us, right? But now there should not be, with needleless systems in practically every facility, there should be no reason why anyone should be holding a syringe with a needle on it unless they are giving a sub-Q such as insulin or heparin or Lovenox, or if you are giving an IM injection. And so, and if you are aware and if you are practicing safe and professional techniques, then it should not happen. But we do understand that accidents happen. Pregnant or breastfeeding women are infected with HIV, can transmit the disease to their child. So in 2010, 162 children were born HIV infected. So the pathophysiology, I always like to include a little pathophysiology in my lectures. The immune system will protect the body by recognizing and destroying infectious agents such as bacteria, the virus, and then the parasite. Any abnormal cells or foreign objects, anything from splinters to transplanted organs, right? We know that anything that does not belong in the body is going to try and reject. So, when an individual becomes infected with HIV, the immune system will function, the immune systems are compromised, and the individual becomes more susceptible to a variety of infections, right? Because now my immune system there's something affecting my immune system, so I can't fight off everything as though I could before the infection. There is a chronic persistent destruction of infection-fighting cells, and these are the Cd4 cells, by the replication of the HIV virus. The Cd4 cell is a type of T lymphocyte with Cd4 receptors on the cell surface called a T helper cell. So normally, when stimulated by a recognized antigen from a virus-infected cell, the Cd4 cell is going to release cytokines. This will activate the B lymphocytes and the killer T lymphocytes in an effort to destroy the invading organism. So now my cells are recognizing that there is something amiss. There is an invader. There is a pathogen. And so my body is now going to work to try and destroy this organism. However, in HIV, in this virus, the HIV will target the Cd4 cell. So it's coming right for that Cd4 cell. The infected individual will manifest various stages of HIV disease over the course of time because that HIV has hit that target, has targeted that Cd4 cell. If HIV infection is left untreated, the individual will eventually pass, usually from an opportunistic infection, otherwise known as an OD. So let's talk about this. Let's talk about this viral transmission. Let's talk about the seroconversion, and then how we become acutely infected. So when a person is first infected, the virus will cause an inflammatory reaction. And we have been talking about inflammatory reactions all semester, right? We talked about inflammatory reactions when we talked about allergic disorders, when we talked about connective tissue diseases. We talked about it with the inflammatory process and infectious diseases. So it is always, 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 ladies and gentlemen, going to come back to an inflammatory process. The white blood cells and the macrophages will arrive at the site of the inoculation of the virus. And we talked about this. We talked about this with infectious disease and with the WBC count and the CBC and the differential. We talked about all of this. The virus particle will attach to a specific receptor on the Cd4 cell. Remember, we just said that the HIV is going to target that Cd4 cell, the Cd4 receptors and the co-receptors, and that is how this virus is going to enter the cell on the Cd4 receptor. Inside the cell, this viral RNA is changed to viral DNA. So now this is how there is replication, right? Because that HIV virus has worked its way into the cell. So now it actually becomes part of my DNA. And then that is how the virus is going to replicate. Viral DNA is integrated into the Cd4 lymphocyte cellular DNA in the nucleus of the lymphocyte. So now this virus is so very smart, and it has worked its way into the nucleus of my cell. HIV DNA is now in charge of cell reproduction and will produce new viral proteins. So this means as there is cell replication, this virus is now part of my DNA. So as the cell replicates, I am actually producing the virus in my body. New HIV viruses are released, and they are able to infect other Cd4 lymphocytes. Cd4 lymphocyte is destroyed, and then new viruses are produced, each time with cell replication. The rapid decrease in Cd4 lymphocyte count and rapid increase in the viral load, which is viral load is the amount of the HIV virus that is in my blood. So when they are looking for this HIV virus in my lab studies, they are going to do a Cd4 count, they're going to do a viral load. After several weeks, the immune system will develop antibodies to the HIV because remember, we are still trying to fight off this virus. Seroconversion will occur. Seroconversion is when the interval when HIV antibodies are first produced, and then they will rise to detectable levels, which means that there's replication, cell replication, cell replication, and then seroconversion will show itself when there is enough of these HIV antibodies in my body to be detected on a lab study. And then this is when the person will test HIV positive. So once an individual is infected with HIV, the immune response to the infection will consist over several stages. So, and here is just the slide of HIV replication where you can see it's entering the cell, and then it is working its way into the nucleus of the cell, and now it is becoming part of my DNA. So then how do we progress through HIV to the AIDS? So there is viral transmission, we talked about that. Then there is the seroconversion, and we talked about that, where I am replicating the virus in my body. So acute viral infection will show itself in 1 to 2 weeks. Asymptomatic chronic infection, I will average 3 to 10 years. So my body may be reproducing this virus within my body for 3 to 10 years before I still may be actually asymptomatic, and I may never know. Symptomatic and then AIDS, the average is 2 years, and then the last stage is the passing, is death. So let's talk about the asymptomatic chronic infection. The Cd4 count will increase to near normal, and then the viral load will drop to a set point. And let's talk about the viral set point. The viral set point will occur when viral replication is still taking place, but the immune system is able to destroy the virus in equal amounts as it is being reproduced. So this means that I still have somewhat of an intact immune system, right, where I am still trying to fight off this virus. So I may or may not be testing positive at this time. The Cd4 count will slowly fall. The individual will lose approximately 50 to 100 Cd4 cells per year. So my CD4 count is dropping, my viral load is increasing, and this may take as long as 10 years. So let's talk about asymptomatic chronic infection. As the HIV-infected individual's CD4 count will continue to fall, control over viral replication will be slowly lost. These are the population where they are IV drug abusers. There may be something going on with their immune system where they already may be immune compromised. So they are going to show symptoms much sooner than a healthy individual with an intact immune system. So individuals will begin to develop symptoms, respiratory tract infections, skin problems, and enlarged lymph nodes. The CD4 count will fall more rapidly, and then there will be a rapid increase in the viral replication. So the CD4 count is going lower, the viral load is increasing. So once they become symptomatic, the average time to AIDS development is 2 years. So now, let's talk about acquired immune deficiency syndrome, otherwise known as AIDS. As the CD4 count continues to fall, the immune system is less and less able to fight off any infection. So an HIV-infected individual will have AIDS when the CD4 count is less than 200 cells. So symptomatic, non-symptomatic, healthy, ill, once that CD4 count falls to less than 200 cells, they are considered to be AIDS positive. Or when they are diagnosed with one or more of the AIDS-defining illnesses. That is the criteria for AIDS. So, commonly occurring AIDS-defining illnesses are the Pneumocystis carinii pneumonia, the PCP, Mycobacterium complex, toxoplasmosis, non-Hodgkin's lymphoma, and progressive multifocal leukoencephalopathy. So, target organs for damage secondary to HIV are the kidneys, the peripheral nervous system, the central nervous system, and the cardiovascular system. So, what are the clinical manifestations? Clinical manifestations in a patient with HIV or AIDS are most often related to impaired immune function and are a reflection of an OI. An OI is an opportunistic infection. OD is opportunistic diseases. OI is opportunistic infection. And these may occur as a result of the HIV disease. So ladies and gentlemen, listen up, listen up, listen up. One of the clinical manifestations will be a fever caused by the infection. And we already know this. We already know that once the body has been infected, one of the things that we are going to see early on is a fever. Other clinical manifestations, a cough. The patient will complain of feeling weak, nausea, vomiting, and then diarrhea. So, other clinical manifestations, dysphagia. We know that dysphagia is difficulty swallowing. They may become forgetful. They may develop skin lesions. Ladies and gentlemen, listen up, and then listen up one more time. Shortness of breath. Shortness of breath, dyspnea, shortness of breath on exertion is a clinical manifestation of the Pneumocystis carinii pneumonia. So shortness of breath on exertion will be a clinical manifestation of PCP. And your client may also complain of headaches. Ladies and gentlemen, listen up. Clinical manifestations, vision changes. They may complain of pain. Ladies and gentlemen, listen up, listen up, listen up. One more time. Night sweats. Night sweats are due to the mycobacterial infection. Mycobacterial infection. And another clinical manifestation is lymphadenopathy. So clinical manifestations indicating a deterioration in status regarding immediate attention by a healthcare provider are, so your client may have clinical manifestations and they may be positive for HIV. So now we have to think about what is going on. How do we know that, okay, this is what's going on with them, but now we are developing something new, and now we need to call the healthcare provider. And that would be a new cough, increased fatigue, a temperature less than 97 or 36 degrees Celsius, or greater than 102, 39 degrees Celsius. A new onset of night sweats. A new onset of night sweats requires immediate attention. A new onset of a headache, new onset of visual blurring, a recent change in the patient's mental status, either noted by them or noted by a family member or a significant other. New skin lesions, a new onset of diarrhea, weight loss that is greater than 10% of their previous recorded weight. Ladies and gentlemen, listen up. This is important. A weight loss greater than 10% of their previous recorded weight. So how do we diagnose this disease, this virus? There is a screening tool, the ELISA. The ELISA test is the enzyme-linked immunoabsorbent assay. So this requires a blood sample. It is not a rapid test. So results will have to be available in 24 to 48 hours. However, a negative screening test does not require confirmation. And this test, this ELISA screening tool, should be repeated in 3 to 6 months because this will allow time for the antibodies to develop and be detected if present. So, if a client suspects that they have been infected, and they go and they have an ELISA screening test, and it comes back negative, but they suspect, or the healthcare provider suspects, that they have become infected, then they need to come back in 3 to 6 months to be rescreened with the ELISA test to see if they are indeed negative or if they are in fact positive. So, a positive screening test will require confirmation by an HIV Western blot. So first we will do the ELISA screening, and then for confirmation, maybe after 3 to 6 months, we will do confirmation by an HIV Western blot. The HIV Western blot test will confirm the presence of the proteins that are unique to the HIV virus. So if the proteins are absent, then the person is not infected. A positive screening test is followed by a confirmatory Western blot, and then this is used to diagnose individuals over the age of 12 months. So this is the same screening criteria that we would use for children. HIV infection can also be confirmed by the presence of the HIV virus in the blood. So we then are looking at the viral load, because remember, when the viral load is high, that Cd4 count is going to be low. They are opposite. The viral load is most often used to confirm the presence of HIV infection in infants that are less than 12 months of age. So we are going to use the Western blot to confirm for over 12 months of age. But for younger than 12 months of age, we are going to be looking at the viral load. HIV positive individuals are screened for comorbidities, and some of those comorbidities are chronic hepatitis B and or chronic hepatitis C. So, diagnostic testing. If there is a decrease in the Cd4 count to less than 200 cells, and they are positive for the HIV status, individuals are also screened for the presence of antibodies that will indicate a higher risk for them developing those OIs, those opportunistic infections, such as toxoplasmosis, TB, and syphilis. Testing is also done for anemia, kidney disease, liver disease, diabetes mellitus, high cholesterol. HIV women are also screened for cervical cancer. So when they are diagnosed, the patient's viral load and the CD4 count are obtained. Because remember, this is the criteria that we are looking at: the CD4 count and the viral load. The CD4 count and the viral load are obtained routinely every 3 to 6 months after they are diagnosed. So these patients are monitored frequently and they are monitored closely. Newly infected individuals may be infected with a drug-resistant virus. So, diagnostic testing. A genotype assay will determine the changes in the viral gene sequence that will make the virus resistant to antiretroviral therapy. These are ART medications, and this is part of the initial evaluation. A genotype assay of viral tropism is a test to determine if there is a CCR5 co-receptor on the Cd4 cell, may be done to help determine the cause of treatment failure and assist with the selection of ART medications. So, HIV treatment is very, very patient-centered. Every individual will be placed on different antiretroviral medications, which are called ART medications, and the treatment is not going to be the same. It is not one size fits all. So ongoing screening for TB is done every 6 months. They are monitored closely. They are screened closely with a positive history for TB. Purified protein derivative, which is the PPD. And then there is the quantiferin TB Gold is used to screen for TB. So somebody who is positive for HIV is going to also be screened for tuberculosis TB, because that can be considered another opportunistic infection. A positive test will require further evaluation for a current TB infection. So, drug therapy prophylaxis. If an HIV positive individual has a Cd4 count of 200 or less, prophylaxis to reduce the risk of OIs, those opportunistic infections such as toxoplasmosis and PCP, is initiated prior to starting their antiretrovirals. So they will be treated prophylactically for toxoplasmosis and PCP before they start their ART medications. Less than 50 cells or less risk will constitute a risk for M. avium complex. M. avium complex is a disseminated infection affecting multiple organs. So prophylaxis for toxoplasmosis and PCP can be discontinued when the Cd4 count has been greater than 200 for at least 3 months. So these patients will not be, if they are being treated prophylactically for toxoplasmosis and PCP, they cannot begin their antiretroviral medications, their ART medications, until that CD4 count comes up. It has to be greater than 200 for 3 months. So this, in effect, they are, besides being treated for these infections, may also at this time having to be making lifestyle changes. Prophylaxis for M. avium complex can be discontinued when the Cd4 count is greater than 100 cells for 3 months. So let's talk about these antiretroviral therapy, these ART medications. The current Department of Health and Human Services in 2014 recommended initiating antiretroviral therapy, otherwise known as ART medications, state that it should be considered for all HIV positive patients. These medications will interfere with the ability of HIV to reproduce itself. So it is going to go and it is going to work its way into my cell so that when my cell wants to replicate into an HIV cell, into a virus-infected cell, it is going to get in the way of that. These patients are prescribed a minimum of 3 drugs from at least 2 different classes. So I did not include any specific medications here because the list is endless. The list is literally endless, and they are coming up with new and improved medications all the time. So prior to initiation of therapy, hepatic and renal function are evaluated because we want to know, are the liver and the kidneys that are responsible for filtering these medications, are they healthy enough to handle the filtration process of these medications? Once ART therapy has begun, the Cd4 count will increase, right? Because the Cd4 count and the viral load are what is going to guide this therapy. So once ART is begun, the Cd4 count will increase, HIV viral load will decrease to non-detectable levels, and that is the goal. That is the goal of this ART therapy, of these antiretroviral medications. This can be achieved in 6 to 8 weeks. The Cd4 count and the viral loads are followed at regular intervals per the guidelines set up. We are going to look at the viral load every 6 months and the Cd4 count once a year. So, adherence to therapy is evaluated at every encounter to maintain a 95% compliance rate. And this is the thing. These patients have to remain committed. They have to remain compliant to their therapy. They have to stay true to taking these medications. Compliance is a lifetime commitment. This is not something that they can do until they feel better and then fall off the wagon. Treatment preparation before starting therapy is critical to success. So these patients are evaluated. How committed are they? How compliant will they be? Treatment preparation before starting therapy is critical to success. So this means that these patients have to be evaluated. Are they committed? Are they going to stay true? Are they going to come in for their testing? Are they going to come in for their screening? Are they going to stay on top of their medications? All of this needs to be evaluated before we even begin the therapy, because if they are not going to be compliant, then this is not going to help them. Ladies and gentlemen, listen up, and then listen up one more time. Megestrol, otherwise known as Megace, and Drobininol, otherwise known as Marinol, are 2 medications that will relieve anorexia and they will stimulate appetite. So these are 2 medications that I like to talk about because these are very, very common medications for this population. So, treatment preparation before we begin treatment. The advantages and disadvantages of therapy are talked to with the patient, the positives and the negatives, right? Because a client has to make an informed decision. And also, we are evaluating them. Again, we are evaluating them because taking these ART medications, these antiviral medications, is a lifetime commitment. They have to know that this is something that I am going to do for the rest of my life. Not until I start to feel better, not as long as I am in a relationship with whoever that I'm in a relationship with, but for the rest of my life. So, they also need to understand why a certain drug combination was selected for them. Again, these medications, they're innumerable. And so based on the Cd4 count, based on the viral load, based on other lab studies that are done to identify which medications will work for them, because again, this is very selective. It is very patient-centered. So if we are living in the same apartment complex and I am, taking ART medications and you're taking ART medications, and maybe I might be out of one of my medications, I can't go over to you and say, hey, listen, can you back me up over here? No, that's not how it goes. It is very selective. It is very patient-centered. Then they need to be taught how and when to take their medications, and also the side effects of some of the drugs. So if they are taking Bactrim, for instance, one of the side effects is anemia and a skin rash, and they need to know this. They also need to know how to reduce any other side effects, and they need to know the effects of the drugs on their immune system. So now we need to talk about immunizations. They need to stay up to date on their immunizations because HIV-positive individuals are more at risk for infections due to their compromised immune system. So they need to know that I need to protect myself. HIV patients with a Cd4 count of 200 or greater should receive the pneumovax every 5 years to reduce the risk of pneumococcal pneumonia, right? We don't want these patients to get any pneumonia, right? But one of the pneumonias that they are going to be sensitive to or more susceptible to would be the pneumococcal pneumonia and then the PCP. Diphtheria, pertussis, and tetanus vaccines should be given every 10 years. However, this population cannot receive a live vaccine. No live vaccines for this population. So, occupational exposure to blood or body fluids should be reported immediately for us. So if you are caring for a patient that is HIV positive, whether they are receiving ART therapy or not, whether their Cd4 count is high and their viral load is low, if you are exposed to their blood or their body fluids, then we need to report this immediately. If the patient's HIV status is unknown, maybe they know that they're HIV positive, but they don't know what their status is. They don't know their Cd4 count. They don't know their viral load. Permission may be requested to do the appropriate screening, which means that we are going to have to ask if we can obtain blood so that we can find out where they are in order to find out how to treat you. Ladies and gentlemen, please listen up, listen up, listen up. If there is visible blood or fluids, washing the area under running water is recommended because we know this, right? That it is the best thing to do. Many people, they're thinking, oh my God, I was just stuck with this needle. And what they want to do is they want to squeeze the injured area because they think that if I'm going to squeeze the area and the blood is coming out, I am going to squeeze out the infected blood. That is not what happens. Do not squeeze the injured area because that is going to increase the possibility of infection because, unfortunately, sad to say, if they're positive, it is once it happens with that needle stick or however it happens, however the exposure is, it's already in the bloodstream. And so you will need an HIV test to ascertain if serosensitivity can be offered. If negative, antiretroviral medications will be prescribed for you, for the healthcare provider. So generally 2 or 3 drugs are prescribed to be taken for 28 days, and then after 28 days you will be screened again. So prevention, let's talk about prevention. Prevention is a critical component of HIV care. Inadequate testing and compliance with treatment plan, remaining in care are barriers to prevention. Remember, they have to stay committed. Critical part of prevention is being tested and sometimes being tested routinely, depending on your lifestyle. Current recommendations state all providers should offer routine screening for all individuals between the ages of 15 to 65. Ladies and gentlemen, listen up, and then listen up one more time. Current recommendations will state that all providers should offer routine screening for all individuals between the ages of 15 to 65. If HIV negative, yearly testing is recommended if you are a high risk, and high risk is defined as being in a community with a greater than 1% prevalence of HIV sexually transmitted infection, clinic attendees, and incarcerated individuals. Antiretroviral therapy is a cornerstone of prevention. When HIV-positive individuals have a non-detectable viral load, risk of transmitting HIV is less than 3%. So again, we need that viral load to remain low, the Cd4 count to remain high. So, some complications. Complications are related to decreased immune function and will consist of opportunistic infections and then malignancies. When the Cd4 count is greater than 500 cells, the individual will have no signs or symptoms related to HIV infection. So we need that the Cd4 count to remain greater than 500 and the viral load to be low. When the Cd4 count is between 500 and 350, there may be increased respiratory illness, dermatological manifestations, such as herpes zoster. Cd4 count between 350 and 200, there will be an increase in infections. The symptoms are fever, fatigue, severe bacterial infections. When the Cd4 count is below 200, again, when the Cd4 count is below 200, that patient is considered to have the AIDS virus. When they have the AIDS virus, they are likely to develop the specific OIs, those opportunistic infections, which are new infections or reactivation of dormant infections. So, those OIs are PCP, cryptococcal meningitis, candida esophagitis, toxoplasmosis, cytomegalovirus, CMV, M. avium intracellular, which is MAC, and progressive multifocal leukoencephalopathy, PML. So, immune restriction inflammatory syndrome, which is otherwise known as IRIS, occurs as the Cd4 count will increase and the immune system is able to respond to the presence of previously acquired OIs. This means that the Cd4 count is so high that it can function as a normal immune system and it will be able to respond to the presence of those opportunistic infections and actively partake in fighting them off. So, nursing management and nursing diagnoses. Risk for infection related to the decreased immune function. The immune system is not functioning optimally. So there is an increased risk for infection. Imbalanced nutrition, less than body requirements. Sometimes this is lifestyle. They're choosing to use drugs. They want to, spend their money on drugs rather than on food. They have no appetite because they're ill. If they are taking medications, that may be taking away their appetite. And so even going through treatment, it may be less than body requirements. Risk for fluid volume deficit related to gastrointestinal manifestations. So this is somebody who's experiencing nausea, vomiting, diarrhea. Risk for fluid volume deficit. Anxiety related to the disease prognosis or the progression of the disease will, of course, Of course, this is going to cause them anxiety. They have this chronic infection, this chronic disease now. And or if the disease begins to progress, of course, that is going to cause them some anxiety. Knowledge deficit related to self-care and the disease process. Ladies and gentlemen, listen up, and then listen up one more time. Knowledge deficit related to self-care and the disease process. So some nursing management, and we are talking about assessment and analysis. Some clinical manifestations that are most often a reflection of the OIs, those opportunistic infections that are associated with HIV, are respiratory illnesses, pneumonia, meningitis, candida esophagitis. Common signs and symptoms of those OIs are fever, cough, weakness, nausea, and vomiting. Diarrhea, dysphagia. Dysphagia, as we know, is difficulty swallowing, forgetfulness, skin lesions, shortness of breath, dyspnea, shortness of breath on exertion, headache, vision changes, pain, night sweats, lymphadenopathy. So, some nursing interventions. What are we going to do for this population? Because we are nurses, we are going to assess, we're going to reassess, and then if we need to, we are going to assess again. We are going to assess temperature, pulse, respirations, their oxygen saturation. So we are assessing vital signs. And we know, ladies and gentlemen, listen up, and then listen up one more time, that fever is the first indicator of infection. Fever is the first indicator of infection. Hypoxemia. Hypoxemia, another word for decreased oxygen. So hypoxemia, or decreased oxygen carrying capacity, may occur as a result of a decreased number of functional alveoli that is secondary to a respiratory infection. We're looking at their weight trends. So ladies and gentlemen, listen up, and then listen up one more time. Weight loss results from caloric expenditure exceeding caloric intake. And we know this, right? Weight loss is just simple numbers. If you are burning more calories than you are taking in, then you are going to lose weight. It only just makes sense. It's a numbers game. So weight loss resulting from caloric expenditure that exceeds caloric intake will affect cellular metabolism, right? So weight loss of 10% or more is going to indicate disease progression. Weight loss of 10% or more will indicate disease progression. Ladies and gentlemen, please take note. The Cd4 count. There is a correlation between the Cd4 count and then the risk of those people developing OIs, those opportunistic infections. So the lower the count, the more suppressed the immune system. Okay, we want that Cd4 count to be elevated, and we want the viral load to be low, because the viral load will reflect the amount of viral replication, how quickly this virus is replicating in my body. So the higher the viral load, then the quicker the disease will progress. So that is why this adherence to these ART medications is so important, because it is these antiretrovirals that are going to keep my viral load low. So a rate of 95% or greater of compliance is essential to achieve this viral suppression. So nursing interventions, what are we going to do? We have to look at the patient's TB status. There is an increase of TB in persons that are HIV infected. We also need to look at their immunization status. Are they up to date on their immunizations? However, ladies and gentlemen, please remember, for this population, there is no live vaccines. We will not be giving live vaccines to this population because there is a risk of them developing the disease that we are vaccinating them against. Depression. Please note, HIV is often still a stigmatizing illness. We know that it is now a chronic infection, but still, people who have it, family members who know that they have it, friends who know that they have it, it can still be stigmatizing. So since HIV is often still a stigmatizing illness requiring the infected individual, family members, and friends to confront behaviors in their lifestyles that will put the infected individual at risk for contracting the disease. Stigma may put distance between the HIV-infected individual and then his or her support system. Nursing actions, ladies and gentlemen, listen up and then listen up one more time. We will utilize universal contact precautions consistently with this population. I do understand we are trying to be very consistent now with contact precautions anyway in relation to COVID, but we will utilize universal contact precautions consistently with this population. Universal contact precautions are designed to prevent the spread of infections between individuals. So, in addition to hand washing for a minimum of 15 to 30 seconds, I always say, happy birthday twice. If you can make it through the song, happy birthday twice, then you've done a great job. So, in addition to hand washing, which is the most important precaution, personal protective equipment may be necessary when we are providing direct care. And so we want to use personal protective equipment when we are providing any type of personal care. Administering these ART medications as prescribed and on time. These medications need to be given on time. So not only do they have to be adherent to the medications themselves, but they have to be adherent to the time that they are taking the medications. They cannot take these medications late. So if they're going to be out and about, then they need to take their medications with them so that they can take them at the same time every day. Sometimes it will help when we are giving patient education to instruct these patients to tie their medications to an activity. After I brush my teeth in the morning, that's when I take my medication. Before I go to bed at night and I'm having my tea or I'm having my bath or I'm getting ready to read my book, I am going to take my medication. So if we can tie it to an activity of daily living, they may remember, before I do this, I need to take my medication. Because maintaining these drug levels is critical in preventing this drug resistance. We need to provide nutritionally dense foods and then small frequent meals for this population. Anorexia, when I'm talking about anorexia here, ladies and gentlemen, I am talking about loss of appetite. So loss of appetite, nausea, and vomiting are common as a result of medications or an infection. And this, as we know, can lead to dehydration, it can lead to weight loss, and it can lead to electrolyte imbalance. We need to provide emotional support because, again, this can be a very stigmatizing illness. It can be very, very lonely, especially if your patient is in the hospital and if they are in isolation. Then even less, then there's nobody dropping in. How are you doing? Because, we have to gown up, we have to glove. And it's a procedure to go in there. So they can be very lonely, it can be very isolating. They may have complex emotional issues such as issues with their sexuality. They may be feeling shame. They may be feeling angry over their diagnosis. So we need to make referrals to mental health professionals that may be able to assist with this diagnosis and how they're coping with this diagnosis. And now, because of medications and because of acceptance and because of all the changes and the fact that these people, this population is living longer, focus should be on living with their HIV and managing their HIV and not on death. So, they may need a referral for social services. They may need some assistance with the cost of their medications. These medications can cost up to $12,000 yearly. It's a very costly process. They may also need support programs, sometimes talking with someone who also has the illness, also has the disease, how they got it, how they're coping with it. It gives them a sense of family. So support programs through the community are often helpful. And then there are local, state, and federal programs that will help them with their treatment plans. So patient education, what are we going to talk about with this population? Well, we need to talk to them about the avoidance of those high-risk behaviors that brought them to this in the first place. And they also need to know avoiding those high-risk behaviors that will increase their risk of transmitting this virus to a partner, to other individuals, to a significant other. So we need to talk to them about the consistent use of condoms. Condoms must be worn at every sexual encounter. They cannot have unprotected sex. They also need to know to use a water-based lubricant. If they are going to use a water-based lubricant, it needs to be, if they're going to use a lubricant, it needs to be water-based and not oil-based, because an oil-based lubricant may damage the integrity of the condom. They need to know to avoid the use of street drugs, well, obviously, no alcohol, and they also need to know not to put themselves in situations where their judgment might be impaired. And then this is where those big, huge lifestyle changes come in, because in times of stress, and we all know this, we want to go back to what is comfortable. We want to go back to what makes us feel good. We want to go back to where we feel accepted. And so it's very hard sometimes for this population to break those ties. They need to know adherence to their treatment regimen. This is essential in managing the progression of the disease. So at least 95% compliance is very critical to their well-being and being successful in living with this virus. So again, taking their medications as ordered and at the same time each day. Again, it is helpful to plan their administration times around activities of daily living. This will help to maintain therapeutic drug levels and will decrease the risk of viral resistance developing. So ladies and gentlemen, please take note. Taking their medications as ordered and at the same time is critical. Implementing infection control precautions at the home. Sometimes there is fear of transmission to other household members because, again, living with the stigma of their disease. If there is a blood spill at home, then the families and the patients should be encouraged to clean the area with a bleach solution. Patients need to know signs and symptoms to report to the healthcare provider. Early evaluation and intervention may reduce the morbidity and the mortality associated with those OIs, those opportunistic infections, and reducing the side effects of their medications. Their maintenance needs, then the higher risk of developing malignancies and those OIs, those opportunistic infections. So, ladies and gentlemen, how do I know? How do I know that I've done a very good job in caring for this client, this patient that has HIV? Well, these individuals can lead a very happy life, a very normal lifespan if they are adherent to their therapy. So again, they need to know that compliance is essential, and they need to know that they need to have a 95 or greater compliance rate with their medications and their therapy plan. The response to their ART therapy will be determined by measuring the Cd4 count and the viral load. We want the Cd4 count to be high. We want the viral load to be low. So within 6 to 8 weeks of initiating therapy, there is an increase in the Cd4 count and then a decrease in the viral load, which is what we want. So, ladies and gentlemen, thank you so much for hanging in there with me for this. This is my last lecture. This is my last presentation for this semester. And by doing it in this realm with the voiceover and not being with you, you are spared the weepiness that usually comes when I have my last lecture of this semester. Please know, ladies and gentlemen, that I so appreciate you showing up and that it has been an absolute honor to be with you this semester. I know that these have been very, very challenging times, and I admire each of you for going through this in such a challenging time. So again, it's been an honor for me to be here with you through this semester, and I look forward to seeing you in September.